Shepherd, 10-year-old dog, presented with straining for about 6 weeks duration. On rectal exam, they found a large bilateral perineal hernia, so you can see the hernial sacs on either side here. We're going to do an internal obturator flap repair. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. So I like to do bilateral ones through a single incision. So I do a horseshoe-shaped incision, and you just need to make sure that we're going far enough down over the ischiatic tuberosities on both sides. These are definitely surgeries that, if you're not really comfortable with the anatomy, it is easy to get lost. What's Carter, you said on 30/30? You can easily get lost, especially if you've got like omentum sticking out through the hernia. The other thing that I've seen happen before is retroflexed prostate. And I've seen people inadvertently thinking that the prostate is a testicle, cryptorchid testicle, have inadvertently done a prostatectomy, which means that you've cut the urethra in half and you've done a prostatectomy, which, interestingly, if you do a prostatectomy in normal dogs, usually they're not incontinent, but if you do a prostatectomy for cancer in dogs, almost all of them are incontinent to some degree. And so, pretty distressing when you are doing what you think is a perineal hernia and suddenly you realize that you've done a prostatectomy. And I've been referred a few of those cases. Dog's getting light.
Yeah, just need some first.
Okay. So, pretty distressing, and I've been referred those cases effectively intraoperatively, because once you've done a urethral transection, you can't get any urine out, and so basically you are in a surgical emergency. So that's the anal sphincter right there. And this dog is nice and skinny, which will make things easier as far as identifying the anatomy is concerned. Can I get some more towel clamps, please? So this is my ischiatic tuberosity here. So I'm extending my incision bilaterally down to the ischiatic tuberosity. And definitely the hardest part of this surgery is identifying your anatomy. You can see a hernial sac right here. What are you holding there? All good? This dog will be castrated as well, obviously. The reason why I do the bilateral exposure at the same time is because I think that I can see much better all of my anatomy. I have a yanker. Grab that. Now you do have caudal rectal nerves on both sides, which you have to watch out for. It's definitely worth your time to use good hemostasis, because if these start bleeding a lot, it's really hard to tell where you are. Okay, so that's abdominal fat right there. Okay. This hernia was definitely... Can I get another set of big Gelpies, please? Okay, so that's levator ani coccygeus complex right here. Ischiatic tuberosity there and anal sphincters there. So that's the other ischiatic tuberosity there. And it's not as bad, anywhere near as bad, so I've got a little bit of a herniation right here. Yeah, great, thanks. All right, so I'm going to cut into that hernial sac. Often we have some fluid in here. Pull it out a little bit. So I'm just tucking all those contents back into the abdomen. All right, now I'll just get my Gelpie a little bit better positioned. All right, so there is the ischiatic tuberosity right there. Just tuck that in a little bit more. Levator ani coccygeus complex there. Hernial sac. Abdominal fat. This is omentum. It can be. You can amputate that if you need to. Try to avoid it. We'll just tuck that back in there like that. All right. Can I please get a Sen retractor?
Just one?
A couple, please. Yeah. Okay, so here's our caudal rectal nerve right there. So we'll have to be careful with that.
Do you need to zoom in? Or?
Sorry, my head was in there. So caudal rectal nerve sitting right there. Okay. Do you want to come around this side, Sasha? Hold on to that. I'll get the other sun retractor down here. So the first thing you have to do is expose the ischiatic tuberosity. Do you see a DeBakey forceps?
Maybe still in the tray.
Yeah. Okay. So I don't use polypropylene mesh here unless I don't have any alternative. So if I can use a muscle flap, that's definitely my preference, because if you can use native tissue instead of a synthetic, you're less likely to get infection. I'd much rather put a vascular thing in there that's going to contribute to healing rather than putting in a synthetic. Okay, so that's where the hernia is right there. Levator ani coccygeus complex, and our sphincter is right there. So the next thing that I'm going to do is, using my cautery, I'm going to just cut along that caudal edge and really trying to preserve that tendinous attachment, because that's the really nice, thick, fibrous tissue, and that's what's going to really hold your suture. Okay, and then I'm going to do almost like a subperiosteal dissection of the internal obturator. And then once I get under that, I'll get my freer elevator, which is here. Freer elevator, and I'm going to try to lift up subperiosteally, to maintain some really nice dense tissue to come with the muscle. And you should get all the way, like you should be able to palpate the obturator foramen cranially. Okay, and I'm staying right on the bone. So now my finger is in the obturator foramen here. Do you want to palpate that? Okay, do you want to feel that? All right, so I'm going to zoom in a bit. That's a better view. All right, so that's the hernia right there. That's the internal obturator that I've elevated right there. External anal sphincter, levator ani coccygeus complex. And then I'm just dissecting forward a little bit, and you can actually completely release the internal obturator from the ischiatic table. Now the sciatic nerve is right up there, so I don't use the sacrotuberous ligament unless my muscle flap fails. Because I've heard stories of people inadvertently grabbing the sciatic nerve with a needle with suture, right? And that would be bad. All right, so now this is our obturator, internal obturator flap right here. Nice and dense. All right, so I'll start getting some suture material, please. And we're using 2-O-proline. Just trying to release that a little bit more. All right, and then we're going to use the flap and attach it to the external anal sphincter and to the levator ani coccygeus. Let's see if we can release that. Great. Okay, so that's our hernia right in here. Levator ani coccygeus, which is a bit wimpy in this dog, I have to say. And then the sphincter is fine. All right, so we need to pre-place these sutures, which means that we're going to place the suture and then put a hemostat on it. I'm going to come, so that's a nice robust bite right here. And come to the coccygeus levator ani complex here. And pre-place that suture. So grab some hemostats, please. Sorry, thank you. Grab some scissors. Okay. All right, so that's our first bite there, and we'll lift that up. Big bite there. Big bite there. Yep. Just go right up against the needle driver. Yep. Hand that off. Some people mix absorbable and non-absorbable suture when they do these. I don't really see a reason to do that. I would just use all non-absorbable. Some people think that you'll incite more scar tissue by using absorbable, like cat gut or something like that, but I'm not a big believer in that.
Do we still have cat gut? Do we have cat gut still?
I mean, like obstetricians still use it in humans.
Oh, to get that reaction.
Yeah. One more bite here. I am going to stand corrected here. Can I get some more? My levator ani is actually back there. Okay, so let's release all of these.
Oh, you mean this one?
Yeah.
So this is just a
coccygeal. That's a coccygeal muscle. It's a, what is it called? Not levator. Levator recti or something like that. Yeah. All right, so I actually have to go from here all the way back to here. Hope you guys can see that on the screen. Little knot there. So see how easy it is to get lost here. Okay. But that may be the levator ani and coccygeus back there. I think that's what it is. And the hernia is usually between the coccygeus and the levator ani. Get some more suture material, please. There. Alright, so I'll tuck this in here and get a nice big bite of internal obturator here. Can you pull that suture back for me, please? And I'm going to get just a nice big bite of anal sphincter. Get a nice big bite of anal sphincter here. You cannot do a simple continuous suture pattern because you have to be able to see exactly where you're placing each bite. And if you do simple continuous, you're going to tighten it up too quickly, so you won't be able to see what you're suturing to. So pre-placed sutures are much more accurate. So internal obturator to anal sphincter. You can see the hernia is already closing. And now we have to go from the anal sphincter to the coccygeus. Yep. Oops. Yep. I'm going to put one more here from the internal obturator to the anal sphincter.
2 hemostats left.
Are there more hemostats?
Are you using straight or curved?
It doesn't matter. Okay. I'm just going to start dissecting the other side. So there's the hernia there. A little bit of a hernial sac. Okay. I'm just trying to get oriented here. There's a lot more scar tissue on this side, so it's a little bit harder to see things. And I'm very conscious of the caudorectal nerve, which is going to be sitting right here. All this is scar tissue in here. And it's hard to see where the nerve is. It wouldn't be this far dorsal. Okay, so now I'm down to sphincter here. And what is this? This is...
Yes, it's coming. Oh.
This could be the prostate. Which, no, I think it's just sac contents. Sometimes they get little lifts in there. There's the caudorectal nerve on the other side. Right there. You guys won't be able to see it very well. Okay, so where is... That's the levator ani there. Or sorry, coccygeus there, levator ani. You can see the hernia going right between the two. All right, so now that I've identified the anatomy on that side, I can go ahead and start tying my sutures on the first side. And I'm going to tuck a lap sponge in there just to try to put some pressure on the bleeding. All right, so now we'll tuck that in. And I'll start tying my knots. Get another needle driver. This is definitely a situation where a slip knot is going to help me put appropriate tension. So look how it tucks the whole...
You need to release.
You can release that. So it really just tucks that rectum right up underneath the tail. Okay. So there's a question, is it a good idea to do a colopexy at the same time? Only if you need to. So in most cases you should not need to do that. Usually a muscle flap.
Urgent triage.
Normally a good internal obturator flap is going to be more than enough to fix the problem. You can see that it's just really tucking that anus right up underneath the tail. So now I'm pulling the internal obturator over to the coccygeus. Yeah. Okay. And Cindy is trying to keep all of the hemostats organized so that I do the sutures in order. Okay. Careful. Yep. And Sasha is here as well. She's a visiting surgeon from MVSC, which was my old hospital, helping us out. Yep. This is a German Shepherd dog. So I'm going to just ask the breed. Yeah. Grab a better pair of scissors. Now I can always add more sutures if I need to, more interrupted sutures. Okay. All right, so we've still got a little bit of herniation here, so I might have to add another internal obturator to anal sphincter suture. Can we get some more suture? I very possibly am going to need more than what we've got out there.
I'm going to just drop all of those in for you.
Sure. So you can just see how much neater everything looks on that side now. So a nice big bite here of internal obturator. Coming over to anal sphincter. One of the big challenges of a ventral hernia is the fact that the penis and urethra are sitting right there. Okay, so we'll get that out of the way now. So I'm just going to have a palpate. That feels great. Okay, really, really good. Okay, so now we're going to tuck that other side of the hernia back in here. dissect ventrally here to get to so my ischiatic table is right there, anal sphincter is there, and coccygeus is right there. I would love for this to get tucked in a little bit better. That feels suspiciously like urethra and prostate.
You feel the tube-like structure?
Yeah, so that feels like prostate. So you could easily look at that and say, oh, that's a cryptorchid testicle. I'm going to castrate him.
And we already got 2 testicles.
Yeah. Okay, so now I need to harvest my internal obturator flap. So who asked me if it would be if I ever put in a urinary catheter? That would have been a good idea. In hindsight, putting in a urinary catheter to definitively tell so now I'm just exposing let's just like with every surgery, visibility is absolutely key. If you can't see, you can't do, in the words of Howard Syme. So that means having good assistance and good retraction. So now I'm just trying to expose that other ischium. I haven't started cutting into the internal obturator yet. This side is actually a bit more challenging than the other side. I'm having a little bit more trouble seeing my anatomy. Imagine you guys at home are probably having an even harder time seeing the anatomy, well, a much harder time seeing the anatomy. So I've got the benefit of 3D. Haven't started live streaming in 3D yet. Stay tuned.
Wow, I can imagine you need a lot of data.
Yeah. Just twice the data. And then the other problem is that people at the other end have to wear 3D glasses. Or like Vision Pro from Apple. Which, mind you, would be very cool. In the chat, let me know if you'd be up for 3D streaming. I feel like I'm on talk radio. If you have a story about an obnoxious cashier, okay, so that's the exposed ischiatic tuberosity. So there's a question, do I like doing a tenotomy of the origin of the internal obturator muscle? I do not generally do that. It requires a lot more dissection. I suppose if you really needed it completely freed up, you could do that. So, nice thick periosteum here. So that insertion is going to be all the way up there in the intertrochanteric fossa. All right, so my finger is in the obturator frame in there. You guys want to feel that?
So you elevated
Right in there. Jam your finger in there.
So you elevated the internal operator
All the way up to that, yeah. That's probably sacrotuberous ligament right there. I can feel that right there. Jam the finger right up back there. There's a really firm band right there,
the side is over there.
right in front of it. Okay, so I've elevated that. Okay, now we'll take that out. A little bit of a bleeder here. Alright, so tucking in the hernia there. Alright. Start placing our sutures. So first one is anal sphincter, which is right there. 2, internal obturator, which is right there. Yep.
Do you want me to swap to the other side?
No, all good. Question, how's everyone doing and what's the hardest procedure you've ever done? I've definitely had some where I wish I was somewhere else instead of in theater. Often it's like a soft tissue surgery where you're completely lost. Like I've had a salivary mucocele. As far as technically challenging, I took a tumor out of the right atrium of a dog under vena cava occlusion. That was really fun though. So challenging but really exciting if it went well. So that's, I don't even think of that as being, I mean it's challenging but it's still really, really fun. Like I do those all day, not all day, but now the bad ones are when you feel like you're lost. Some fractures can be quite challenging where you just cannot get it to go back together. And you're just wishing that somebody could come in and scrub in and take over, but then you realize that you're the only one. So another internal obturator flap here. Now that I've got the anatomy isolated, it's actually quite straightforward. Okay. come up from internal obturator to coccygeus. Okay, oops, nice and short. Flip it over up here. So this is another coccygeus 2. Internal obturator. Okay. This will be my last coccygeus to internal obturator. And now I'll come across and do my levator ani. Sorry, internal obturator, no, guess again. Coccygeus to external anal sphincter. So that's anal sphincter there, and that's coccygeus there. It's very handy that this is a nice big skinny dog,
Yeah.
making everything
It's
look
like,
very easy.
oh, it's hard to tell.
More proline, please.
You already gone through all that.
I've got one more here. Never mind. Don't think I'll need it. All good. Thanks. Yeah. Final answer.
Yeah, just for you.
Thank you. So there's a question, why can't we do gastric bypass for dogs that are overweight? I think that there's always a behavioral management option for dogs for weight loss. And you want to make sure that they're not hypothyroid or something like that, but I don't think that, unless the dog is, stealing food from the cupboards or something like that, there's always an owner management solution for weight loss in dogs. So I don't think that gastric bypass is reasonable. The other thing I have done in a few dogs is, if I have a life or death situation, bilateral cruciates or something like that, in a morbidly obese dog, I put those dogs on thyroid medication even if they're not showing that they're hypothyroid. And this was back in the time when we had a shortage of TSH to do TSH stims on dogs, and we had to treat them for hypothyroidism based on clinical signs. And in some of those dogs, even without a definitive diagnosis, I put them on thyroid supplementation. That's all right, Cindy. You can let that down. And resolved refractory obesity. I'm not saying that you should do that in every case, but if I had a dog that was going to be euthanized, if we couldn't get it to lose weight, it's something to consider. Basically just turning up the idle on the engine. I'm sure that if there are any internal medicine specialists watching this, they would be absolutely revolted by what I'm suggesting. I'll come here and do these next. But drastic situations sometimes call for drastic measures. So again, everything's retracting really nicely into place. Yeah. Thank you. If I weren't trying to conserve suture, I would be doing hand ties on these. But hand ties use a lot more suture than instrument ties. Can I get another proline, please? So that's nice and solid there. I've just got a little gap right here in the middle of the peace sign, the Mercedes-Benz sign, that I'm going to fill in with a few more little sutures.
So in what scenarios are you using mesh?
So there's a question internally, what scenarios would I use mesh? And that would be situations where I'm not confident in mostly the coccygeus muscle, the integrity of that. Do we have saline already on the table? There's a question, does every dog and cat need a cone after surgery? Yes, 100%. We've definitely had cases that have gone home and completely destroyed their surgery sites. Okay, so remove that and that. And that's pretty much it. So that looks great. I'm really pleased with our repair here. This one's a little bit neater. But that looks really good.
Yeah.
So that, I think, it's totally fine.
Yeah.
There's just a little bit.
Cool. Yeah.
Okay, so we'll lavage. And then we'll get maybe some OPDS. A little bit of a bleeder here. All right, and we'll get our suction. Yep.
Is this just a gap between the...
Yeah, so there's just some connective tissue here, but that's not into the hernial sac. All right, so now I'm just going to put some temporary towel clamps to just try to align things back up generally. Okay. And I'll address this before anybody has a chance to ask. I would not put a drain in this because in this contaminated area, a drain would be a perfect opportunity for ascending infection to create a big abscess. And this is, there is not a lot of drainage fluid accumulating in here. And so, no, I'm not going to put a drain in it. I'm also not going to tack it down to my muscle repairs because I'm concerned about putting tension on it and having that get disrupted. You want to switch sides? I'm switching the direction of my suturing.
And if there was a ventral component, would you then consider setting?
Membranosus flap, yeah. So there's a question internally, if I had a ventral component, would I do a semimembranosus flap? That is the appropriate flap to do in that situation. So if I had no choice, I would.
Yeah, I have some surgeons who finish in that scenario.
Yeah, ventrally. It's just, have you ever done a ventral? They're so hard to get to. And you've just got lots of really important things that are right in your way, like urethra and stuff like that. Urethra's... Feel free to tell me if my head is in there. Alright, I'm going to come in from this side now. Like I always say, if only one of us can see, it probably should be me. I had somebody actually comment on a live stream, surgery was good, but the videography was terrible. Don't let it happen again. My response was, you get what you pay for.
I was gonna say it's free.
And if you were the one that made that comment, I hope you're watching. And you know how annoyed I was.
You can get a premium version for this if they have the installation.
I used, to close the defect, I used polypropylene or proline.
The video is great, apparently.
Good. Thank you. I did a brain surgery once and somebody put in the comments, B+. Oh, I thought that was very funny. It's like, that is awesome.
Is that the one have the human surgeon scrubbing?
What's that?
Is that is that surgery that human surgeon?
No, different one. Thanks, Alejandro. And Alejandro, I can assure you that your English is better than my Spanish. So. Potential complications here. Other than anesthetic risk, these can get infected, probably 5 to 10% of the time, because it is a contaminated area. You could have recurrence of the hernia. Occasionally, you could inadvertently entrap the sciatic nerve. I guess the other risk would be fecal incontinence because we damaged both caudorectal nerves. Never seen it happen, but I mean, they are both sitting right there, so it makes sense that that would be a possibility. I think I might come across. Close that as a little extra vertical incision.
Charles, what plate did you use for the cat?
What plate did I use for the cat? A 5-hole 2.4 millimeter locking plate.
So you didn't use a TPO?
No. Thank you. Can I get some more OPDS?
Yes, ready.
Thank you. Functional recovery after these, bilateral or unilateral, they should still be pretty good. Like as long as you don't have recurrence, I don't think it makes a big difference if they're bilateral or unilateral. The person who's asking if they didn't hear if their question was answered, can you repeat your question, please? Now I did put a purse string in. which we will obviously have to remove. Can you go over there and just scroll up and see what the other questions were on the chat?
I think it's about the anal sphincter have necrosis. Can it be repaired?
How far do you want me to go up?
That's good for right now. So if the anal sphincter has necrosis, I've never seen that happen before. I would imagine, I mean, you can resect half the anal sphincter. As long as you reconstruct it, you're not going to have an issue with fecal incontinence. I've done that many times with anal sac adenocarcinomas. So I think that by itself, necrosis of the anal sphincter, number one, never seen it. Number two, if I did see it, I think that if you can, if it's limited to a small area, you could resect it. If it's not limited to a small area, I think so antibiotic-wise, we just used cefazolin during the procedure. We will not continue this dog on antibiotics afterward. There's no reason to do that. Retract that ventrally, please. As veterinarians, we need to massively reduce the number of antibiotics or amount of antibiotics that we use, or the right to prescribe antibiotics is going to be taken away from us.
So in your orthopaedic cases, you don't send home with antibiotics, you just give...
Definitely not. Yeah. If I have a contamination or something, I might, but if it's just a routine orthopedic case, definitely not. And there's no evidence that it reduces infections in the first place. All right. It's not the prettiest bottom. Just putting in a little cruciate suture here that we'll have to remember to take out. It's interesting how asymmetrical this came out. I thought that I was going the same distance down on both sides.
Well, the end is still in the middle. I think that's good.
Yeah. It's not pooping to the side. That's great. Yeah. And how do we ensure the transposed muscles maintain adequate vascularity? It shouldn't be an issue. Like your blood supply from the internal obturator is going to be coming from cranially. So I don't think that devitalizing the internal obturator muscle is an issue at all.
Do you think that's good here?
Sure. Yeah. You can put a few along there. All right, so that's pretty much it. We're going to go ahead and end the live stream. I might flip back and just make sure I haven't missed.
I think there's one comment about a small breed versus large breed.
Yeah. All right, so special management to prevent hernia recurrence. You just don't want them straining. And so maybe putting them on stool softeners. I like fiber, like in the form of bran or something like that, or Metamucil. I think that that's a really good idea. The flap to cover the ventral component is called the semimembranosus flap. This is a 10-year-old dog. Still going back and looking at other questions.
Yes. who's doing the castrate?
Cindy and Sasha.
You do one test each.
So I saw a case of a bilateral perineal hernia in a toy breed a few days ago. After the surgeon did the surgery, there was a rectal prolapse and the bladder was still there in a bulge that developed 2 hours post-op. So either regarding the rectal prolapse, that can happen in any patient that's straining. You might think about something like a purse string or something like that, or potentially a colopexy. But if the bladder was back there, you haven't fixed the hernia, basically. And so either the internal obturator flaps failed or it's gone ventrally. If it's gone ventrally, then a conventional internal obturator flap is not going to repair it. Hi, Iran, Turkey, Mexico, Canada, UK, and Bosnia. All right, I'll just get at the bottom to make sure. So there's somebody commented that they had a problem with the dog. The owners, I assume the owners didn't give the medication. The dog licked, so the sphincter was all destroyed. Can't imagine that the dog licking would cause necrosis of the sphincter. I'm not sure exactly what the cause of that would be. And so I understand that Alejandro says that he always operates bilateral ones separately, one incision on the right, reconstruct one incision on the left. I like the U-shaped approach because I think you get much better exposure of all of your anatomy, and so I think it's easier to see what's going on. All right, so that's pretty much it. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications.